Some women cope with excessive hair growth in unexpected areas of the body. Hirsutism is a condition where women grow coarse dark hair in areas usually associated with men. They include the face, the chest, or the back. To better understand the physiology of hirsutism and the treatment options that exist, we have Dr. Amy McMichael, an expert on the topic. Dr. Amy McMichael has served as the chair of the dermatology department at Wake Forest University of Medicine for over 2 decades. Her areas of expertise include hair and scalp disorders and skin of color. Dr. McMichael is the co-chief editor of the medical textbook Hair and Scalp Disorders for Medical, Surgical, and Cosmetic Treatments, where she co-authored a chapter on hirsutism and hypertrichosis. She's a past president of the Skin of Color Society and a past chair of the National Medical Association Dermatology Section. She also served as the vice president of the Women's Dermatologic Society. And to top it off, in her free time, she's also the editor on the editorial board for JAMA Derm, Cosmetic Dermatology, and The Dermatologist. Dr. McMichael, welcome. I'm looking forward to our discussion today on hirsutism.
Thank you so much. It's my pleasure, Hannah. I'll have to just make one correction. I've only been chair for 10 years. I've been at the department for 27 years, but only chair for 10. So I don't want to steal anyone's thunder.
I think 10 years is enough for us to know that you're definitely an expert.
Well, thank you.
So I want to start off with answering maybe a basic question for many and not so basic for others. What is hirsutism and how does it differ from hypertrichosis?
Well, I think it's what you said. I think it's when women have hair growth in a place that is usually considered a secondary characteristic of male, of the male species, male humans. So, it's just like you said, facial hair that's terminal on the, upper lip, chin, chest, around the lower abdomen, where men typically have secondary characteristic hair growth. So those are places that, we kind of think, okay, that should not be happening in women, but we know, obviously it does a lot of the time, and there are lots of reasons for that. Hypertrichosis, on the other hand, can be any kind of hair. So it could be vellus hair, which is the very fine baby hairs, intermediate hairs, which are kind of between those little fine vellus hairs and terminal hairs. And it could be anywhere on the body, but not in those areas that are typically thought of as a male secondary characteristic.
What causes it and who is most at risk?
So hirsutism is typically caused by some unknown, hormonal variants. And, if you look at the majority of people, and you all comers of hirsutism, not those who necessarily seek out dermatologists, but if you look at those who come in, it's usually some sort of ovarian abnormality. And a lot of times it's just, that the receptors on the hair follicles in that particular patient, probably, this is genetic, from some person in their family. They're, even though they may not have higher levels of male hormones circulating around, their follicles sort of bind to the hormones that are there, because all women, of course, have androgens or male hormones. Their follicles bind to those androgens and just get stimulated by them. So in an individual patient, unless it's something that we think is going to harm them, medically down the line, we usually don't pursue a tremendous amount of evaluation. Now, in a person who comes to me with hirsutism, I take a very detailed history about their menstrual period, because that's going to be the most sensitive thing to hormonal abnormality, about any other secondary male characteristics that they might be experiencing, fertility issues, problems with deepening of their voice, clitoral enlargement, any, hyperactive sex drive, any of these things can tell us, okay, there's more here to the story than just facial hair. We need to kind of get more information. In a general person who, has a normal menstrual cycle, very predictable periods, you don't have to really do a whole lot. I might get free and total testosterone in that person, just to make sure I'm not missing anything. But in the other person that I talked about, where they have a lot of other things going on, that's when you have to sort of set into a search. Look at
Okay.
TSH, look at your hormone levels, total free and total testosterone. DHEAS is a little bit outdated now, so I don't get that as much. And I might get LH and FSH, and that's usually kind of where I stop. And then I start working with my friends in endocrinology, sometimes in OBGYN.
Very good. So, you mentioned testosterone levels. Does it usually, if you have higher testosterone, is that a direct correlation with the degree of how much hair you might see on your chin or in your chest?
Certainly there can be that correlation, but it's not always. So as I said, people can have, completely normal free and total testosterone, but it's just that their receptors are just sort of upregulated, and so they have a tremendous amount of hair on their face, or and or chest. So it can correlate, but it's not a direct correlation in every patient.
And what are the typical, I understand that there's usually non-androgenetic causes and then versus androgenetic causes. Can you share with us what those are?
Yeah, so as I said, the thyroid hormone abnormalities can certainly set this into motion. Pituitary abnormalities, so if you have a pituitary tumor or overproduction of pituitary hormones, that can start a cycle, where your hair growth starts, and as well as other things. Outside medications can do it. So if you take medications that have testosterone in them, that sometimes happens inadvertently when people take medications that they don't know have steroid in them, like medications for weight loss or for energy. A lot of times they don't recognize that DHAS will turn into testosterone at some point in the cycle. So it can happen inadvertently, but it can also happen if people are doing muscle building exercises and they're taking steroid for those reasons. Those are probably the major. You can have ovarian tumors. Tumors of other kind that just have hormonal production with a lot of very high corticosteroid production. Even corticosteroids can do it, although you typically see more hypertrichosis with drugs like cyclosporin and that sort of thing. You sometimes see a little bit of hirsutism as well.
Is there typically a relationship to infertility, or this has, there's some discussion that maybe if you have hair in your chin or hirsutism, obviously with PCOS, that can definitely be a correlation with infertility. But do you see that across the board, or it really varies based on the cause?
I think it really varies. I think that polycystic ovarian syndrome is really an umbrella term that houses a lot of different kinds of disorders underneath it. So under that disorder, you have sort of those people that have that upregulation of hormone receptors, as well as those people that have really pretty significant other issues like fertility kind of problems, that sort of thing. And I don't depending on whose study you look at. If you look at the endocrinology studies, you get one percentage of how that goes. And if you look at the people that come and see OBGYNs, it looks like another thing. And if you look at the people that come and see dermatologists, it looks like another thing. So we don't have great specific, guidelines on, how many of each there are. But I do think that, you take, when you're seeing patients as a doctor, you take each individual patient and sort of go with what they are telling you. I have a lot of young women that come in and they really have no idea what their fertility issues are because they haven't tried to have a baby. They've
Right.
either been on oral contraceptives or just, on nothing and haven't ever tried. So sometimes we don't even have that information to go with. But if they do have, other things going on, if they're overweight, difficulty losing weight, female pattern hair loss, hirsutism, then we start to get the hint and, may do more workup. And obviously, that person might be a little bit more at risk at that point. But, I think it really does make sense to evaluate every person specifically. Now, if you look at populations, more epidemiologic, I'd say probably um, the there is probably a one-to-one correlation in about 25 to 30% of people maybe.
Is there ever a family history that you see?
Oh yes, very, very commonly. I think that a lot of this is genetic, how people process their hormones, and it can come from any side of the family. So the male side, the father side, mother side, it could come from an aunt that's kind of distant, and you just those chromosomes just hopped on. and you're displaying those changes. So yes, we see a quite a bit. A lot of times mothers will bring their daughters and say, I had this, I don't want them to suffer, let's start working on this now. So yeah, we really do see it in families.
And what is the typical age range that patients start to, maybe patients don't come to you right away, but where they first
Mhm.
start to notice it, and want
Yeah, I think the
help?
20s.
The
Yeah, I think the
20s.
20s, 30s. I think there's a couple, it's like bimodal, sort of humps there. I think the 20s and 30s are when it starts for the patients that probably have those hormone receptors. And then you see another group is, kind of when they're postmenopausal, they start getting those, wiggly chin hairs. They don't like those, and it's because their estrogens are going down and that sort of thing. So you'll see a little bit more growth at that point. But probably by and large, the biggest group is around the 30s.
What diagnostic tools do you use when you're examining to really assess if this is hirsutism? Do you use the Ferriman-Gallwey scoring system? And are there other parts of a physical exam you do? Like, I mean,
Hmm.
as a dermatologist, you're probably not doing a pelvic exam, but I'm just curious what your typical routine is when you see a patient in clinic.
Hmm. Yeah, I usually, put them somewhere on the Fairman-Galley score, which is really a scale that we use mostly for research. If we're trying to document where people are, it's a nice way to sort of say, okay, out of, this number, you have, this much severity at this site, and, then you add it all up, and obviously there's a score there. And I think that's very helpful if you're doing research. Now, if you're doing a day to day, the only reason you might do it is so you don't have to take a picture of the person. Now we have charts where you can throw pictures in there. And if people don't mind, you can say, okay, we're starting here. Now we're going to start treatment, whatever that treatment might be. And you don't really need to do a whole lot else in terms of, grading them on a scale. So I look at their face. I ask, I maybe look at their chest. I ask them about, other areas on the body. I look to see if they have acne, because that's another thing that, can go along with this hormonal kind of stuff. I look to see if they have any hair loss. And they may have hair loss that may be totally unrelated to their hirsutism, because there are lots of different kinds of hair loss. And really, that's, the physical exam is all you need. You'll see a lot of times, just the terminal hairs themselves. People do a very good job of plucking, so you have to look very closely. Sometimes you can see the stigmata of hair removal, and particularly in women of color, you can see a lot of post-inflammatory hyperpigmentation and pseudo-folliculitis barbae, where there's the inflammation around the hair follicle from the hair itself, as well as from the removal of the hair. So those are all giveaways. A lot of times I'll have people come in and they say to me, I want to get these dark spots to go away. And I look, okay, let's back up and let's think about why the dark spots are there. They're there because the hair keeps coming out of the hair follicle and you have to remove it. And so really what we need to do is remove the hair to get the dark spots, because you can chase dark spots, from post-inflammatory hyperpigmentation and pseudofolliculitis barbae forever, and you'll never get it under control if you don't get the hairs out of there. So it's a story and a reason why it's good that they come in to see a board certified dermatologist to get that story and to understand why they're not winning their fight against those dark spots. So it's a nice way to sort of help them understand and also get the appropriate treatment.
Yeah, those dark spots can be a nuisance and often like the only reason someone comes into the clinic. So I totally understand what you're saying. When you mentioned hair loss, which is often, you say, commonly seen
Mhm.
with hirsutism, is it typically androgenetic alopecia, or which is female pattern hair loss, or is it, as you said, it could, there's so many different reasons why you can get hair loss, but is that the most typically correlated with hirsutism?
Yes, absolutely. That's what we normally see. We normally see pattern hair loss, so thinning on the vertex scalp, maybe a little bitemporal thinning, maybe a little bit of thinning around the preauricular scalp as well, in the frontal area. Other forms of hair loss may exist, but they're not typically associated with the hair on the face if you have polycystic ovarian syndrome. So I look, and I mean, obviously, if somebody has a patch of hair loss and it's alopecia areata, we treat it, but I don't worry about it being indicative of some other underlying hormonal problem.
Okay. And do you often see that hirsutism gets worse with age? I feel like my mother all the time, she's like, I just got my chin waxed, which obviously waxing your chin is not a permanent solution. And like the next and within a week, her hair is growing back. So is this common that as women age, that it just seems to get worse and you get more hairs?
Yeah, unfortunately, if that's in your genetics, yeah, it is. We see those little ladies with those little, or little ladies with those little hairs on their chins. And yeah, unfortunately, we're all headed that way. But yeah, obviously, there's some people are kind of hairless and they won't get it. But it's very, very common. As your hormones change, you get postmenopausal, the estrogen levels and testosterone and androgen levels all change. And so, there's some genetics there and then some hormone stuff there, and it all mixes together to make us little hairs on our chinny chin chins. So, yeah, unfortunately, that is
We have
something
a lot to look forward
that
to.
comes. Yeah, yeah. Not the best news, but the good news is we've got lots of stuff to treat it now. So you can come in and get your hair treated.
So we'll talk about that. I just want to touch before we get to treatment. How about in pregnancy? Is it something that you also see gets worse in pregnancy? And women who are pregnant can have certain treatments. So what do you recommend that they do about it?
So I see it a lot in pregnancy, but I don't think it's necessarily worsening in pregnancy. I think it's, worsens a little bit after, so after you have the baby, sometimes you can see a rev up of the hormones. I have a lot of women who have polycystic ovarian syndrome. They'll do fertility work to get pregnant, for instance, and then it will be in a phase where they're doing really good after treatment, and we'll go into that later. And then after they have the baby, they'll come back in, usually it's a year later or 9 months later, and I mean, it'll just be revved up, but during pregnancy, it's like pretty good. Like your hair grows really nicely on your head, your face looks beautiful, but by the same token, you can have someone that has some worsening of hair growth during pregnancy. It's probably a little bit on the rare side. It's just the same as I'll see sometimes people with really, really horrible acne during pregnancy. It's something that's so difficult to treat because you obviously want to take care of the patient and the baby. And so you have to kind of wait a little bit before you can really get in there and treat. But I have some women that get the most horrible cystic acne, and sometimes they can have a little hair growth along with that. But most of the time, it's pretty well controlled during pregnancy.
Right. So what medications should be avoided? They say that skin irritation from retinoic acid can cause hirsutism. Is this a true fact? And what should women avoid?
I don't think so. I don't think retin-A does it. I think, this is all genetics. This is all hormonal. It's all coming from the inside. You're not making any of this happen from the outside. So I think there's really not anything to avoid other than, hormone, taking like testosterone. I think don't use testosterone creams, don't use testosterone orally. I have people who go to functional medicine physicians, and I don't have anything against functional medicine physicians, but they're also oftentimes playing with your hormone levels. And I will see both hair loss in the scalp and hair growth on the face, when they start all that, teetering around with hormone levels. So I think you have to be very careful. You certainly might get energy from testosterone, but if you have facial hair, you're going to be, walking a tightrope trying to keep your hair growth down, and you might have energy to do all kinds of things, but you still have to spend your energy taking your hair off if you take hormones. So I'm very careful about, recommending that people talk to the primary care doctor. And if they really do have hormonal abnormalities, recommend they see, a fellowship trained endocrinologist, because, I think that you can do a lot of damage, it's kind of monkeying around with hormones. So I would avoid that, kind of those unknown, uh, you know, things that people take when they're trying to exercise and build muscle and all that. I would probably avoid it. If you don't know what's in it, you shouldn't take it. Um, and those are and then they also have these, like, I have a lot of people now are telling me they go to these functional medicine doctors, they get these pellets, hormone pellets implanted. Please don't let anybody implant pellets of hormone into your body. That is not a good recommendation. And, it's not going to, it's like an anti-aging kind of treatment. And it's really a poorly studied practice. And so until we get more information, I think we should all avoid that.
Thank you for sharing that. So
Mhm,
let's get to the moment that a lot of people are waiting for, and that's talking about treatment options. What
mhm.
is first line for hirsutism? And what do you typically use on your patients?
First line, by and large, is going to be laser hair removal. But the caveats with laser hair removal is that you have to have the right laser for the right patient skin color. So for our fair skin patients, we're using diode laser. For our darker skin patients, we're using ND-YAG laser. Um, and the other caveat is that you have to have dark hairs. So unfortunately for people out there who have gray hairs, the laser can't see that. You know, the lasers work by being attracted to a color and they don't see white. So we can't treat you with the laser anyway if we're doing laser hair removal. So that has revolutionized hair on the face. I mean, trained in a time where there were no lasers really other than um, uh, pulsed dye laser for hematologic abnormalities. And I mean, that was pretty much all we had. And thank goodness, Roxley Anderson and his, ever amazing mind, kind of figured out this whole chromophore thing for hair. And of course, we started out with, these ruby lasers and then went to alexandrite lasers. And now we've sort of honed it down to diodes and Nd:YAG. And so that's what's going to be your first choice. You want to go to somebody who knows what they're doing with lasers, not just your, laser place on the corner next to the bike shop in the Chipotle. That may or may not work for you. I mean, they may be actually well trained, but oftentimes they're back office people that are given a little bit of a course and then they turn the laser way down. So you might get some epilation and the hair goes away, but it doesn't stay away. And that particularly happens in darker skinned people because when they first started doing all these little laser shops on the corner, they were burning people. So now they know better. They turn the laser way down, but they don't give you lasting results. So you really want to go to somebody who is this, board certified dermatologist, knows what the heck they're doing with the laser, has experience in your particular skin color, and can really give you the best outcome. And everybody's going to be different in how they do with laser. Some people who have a lot of hair, it's going to take a lot of treatments. People who have polycystic ovarian syndrome, if their hormones are, still pumping, you're going to have, really good maintenance. So get your 6 to 10 treatments, depending on how severe your hair is. And you may need to follow up every 6 months, with laser hair treatment because those hormones are still pumping, but you'll never have as much hair as you had before you start. So it's laser, we think of it as permanent hair reduction. Now, for the white haired people, what can you do? Well, there still is electrolysis. Electrolysis was the way we treated it in the good old days. I went to a small practice in Tennessee because there was hardly any place to learn how to do electrolysis when I came out. I really wanted to treat people, with hair for their hair growth. So I went to this little practice in a little town in Eastern Tennessee, and they taught me how to do electrolysis. And I taught a couple of people, and then I ran into an electrolysis ordinaire extraordinaire who lives here in the area, and she partnered with us for many years. Where our partnership just ended during the whole COVID nonsense, so everything has changed, since COVID. But she for years would come over and treat our patients every Thursday all day for those people who had just a few hairs or white hairs. And she still has practices in town. So luckily we can still send our patients to her there. So the good news is that you can maybe find somebody who still knows that technique and can do it safely in your area and just partner with them. Or you can bring someone in and teach them. Obviously, you could do that too.
Right.
And it's slower, it takes a lot longer, but you can do any kind of hair anywhere on the body. And it just takes a really long time, but it can work. So those are kind of how we do with the lasers and some sort of invasive treatment. But you can also work with topical. So there's a topical medication called eflornithine. We did the research on that topical medication, which is a brand name Vanica years and years ago. It's changed hands a bunch of times, and unfortunately now it's very prohibitive in terms of cost. I don't know who even makes it, but it's ranging in $140, $150 for a tube. But it slows the growth of hair, and it can work really well. And you can use it along with laser if you can get it for your patient. Another way you can do it is spironolactone. Spironolactone orally, obviously, is a drug for blood pressure control, is a diuretic, but it binds to the male hormone receptors on those hair follicles and can slow the growth of hair. So obviously, if you're doing spironolactone or Vanica, those are not going to be reducing your hair long term. When you stop them, it'll return to the normal baseline. But they're helpful treatments. And certainly we have people who can't either afford to do laser, don't have time to do laser, too young to do laser, lots of different reasons. So those are good things for our patients if we need to use them.
And you didn't mention oral dutasteride, or how about oral contraceptives? Are these still
Yeah,
medications you consider, or even finasteride when someone comes in and may not want to do laser and they want an oral
yeah.
therapy?
Unfortunately, finasteride and dutasteride don't work great for facial hair growth, so I don't use those for that. I do use it off-label for pattern hair loss, and then obviously it's on label. Finasteride is on label for male pattern hair loss, but no, I don't feel like those work very well for facial hair. Unfortunately, on the other hand, oral contraceptives can be very helpful. Again, not long term. If you get off of them, your hormones revert back to what their normal baseline levels are. But so that can be helpful. And that's actually, if you look at the data, it's actually first line, but relatively um, few patients will want to do that if they're not already on them. And I don't manage people's oral contraceptives because I don't do vaginal exams. Some people feel very comfortable with that, especially, doing it for acne and that sort of thing. At this point, I usually don't do that. But patients tell me all the time, when I was on it, my hair growth was more organized and regulated. And as soon as I got off, things went crazy and, that sort of thing. So it can be helpful.
Okay, well, thank you so much, Dr. McMichael, for sharing this with us today. I think a lot of people will find it interesting. I know I certainly do, and it was lovely speaking to you.
Oh, it's been my pleasure. Thank you so much, Hannah.
I hope you enjoyed this episode of the Derm Club podcast. If you found the discussion today to be valuable, please subscribe and share. I look forward to seeing you in the next episode as we continue to delve into dermatology and skincare with the world experts.